Now I call upon Dr. Suma Natarajan.
Respected chairpersons and friends, thank the BSOG for having given me this opportunity. My discussion will go on the following subheadings: prevalence, effect of pregnancy on fibroid, fibroid on pregnancy, and management during pregnancy and labor, and the most controversial role of antepartum myomectomy, cesarean myomectomy, and conclusion. Now, looking at the overall incidence, it's around 40 to 60% by the age of 35 years and 80% almost by age of 50 years. But of course, in the prevalence of the fibroid in pregnancy is around 1.6 to 10.7%. 42% of the large fibroids can be diagnosed by physical examination. Now, if you look at the growth of these fibroids, the fibroids will increase in size by about the end of first trimester to the early second trimester, and further growth is very less after the second trimester. Now, most of the large fibroids grow to some extent and then they stop, but some smaller fibroids are likely to remain stable, and the fibroid volume during pregnancy mostly increases by about 12%, and very few fibroids increase by about 25%. Now, I think was one of the symptoms of fibroids in pregnancy. Almost 90% of the patients with fibroids are asymptomatic. The main three symptoms that you see are pain, pelvic pressure, and vaginal bleeding. Now, pain is the most common symptom with fibroids, especially with over 5 centimeters in diameter. And usually they're present in the late first trimester or in the second trimester. And most often it is secondary to red degeneration or torsion or necrosis of a pedunculated fibroid. Now, this is some of the cases that we had seen in our practice. Now, pain associated with red degeneration, there are main three theories. One is the rapid fibroid growth, which results because of tissue outgrowing its blood supply, leading to tissue anoxia, necrosis, and infarction. The growing uterus also can change the architecture of the blood supply to the fibroid, leading to ischemia and necrosis, and release of prostaglandins from the cellular damage within the fibroid. Now, looking at the effects of fibroid in pregnancy, most of the women do not have any complication. So again, 10 to 30% of them may present with red degeneration, but however, there are no well-designed studies that provide high-quality data. The effects of fibroid in pregnancy outcome: early pregnancy, most common problem that we come across is miscarriage and bleeding, and in the late pregnancy, preterm labor, placental abruption, placenta previa, and fetal growth restriction and anomalies. Now, during labor and delivery, you could experience the malpresentations, labor dystocias, and Caesar deliveries are much more common in patients who have fibroid with pregnancy. And postpartum hemorrhage and retained placenta are some of the problems that we come across. Now, let us look at miscarriage and fibroids. The actual mechanism is unclear, but however, the mechanisms that have been proposed are increased uterine irritability and contractility, compressive effect of the fibroids, and compromise of blood supply of the developing placenta and the fetus. Now, most common cause of miscarriage is usually a submucosal fibroid, whereas the other types of fibroids are not really the cause for miscarriage. Now, the size of the fibroid, again, a bigger size of the fibroid pressing on the placenta could give rise to miscarriage. The multiple fibroids are again an increased risk for abortions. Now, bleeding in early pregnancy is mainly the location of the fibroid determines the risk of bleeding. Bleeding is more common in patients where the placenta placenta close to the fibroid than the control, 60 versus 9%. Now, preterm labor. Women with fibroids, they are more likely to develop preterm labor than controls. Now, this study shows 16 versus 8.7%. And the main risks are multiple fibroids, fibroids coming closer to the placenta, and a size greater than 5 centimeters. Again, the biological basis behind this is again a fibroid uterus. Fibroid is less distensible compared to the uterine muscle. Hence, the contraction can occur with the uterus distance beyond a certain point. And it is also, studies have shown that decreased oxytocin activity in the gravid uterus can increase in the oxytocin levels, but however, they're just all not really proved. Placental abruption, in my own experience, we have not really seen too many cases of placental abruption, but pooled cumulative data shows that there is a threefold increased risk. And they are common with submucosal fibroids, retroplacental fibroids, and fibroid volumes of more than 200 centimeters mercury. I mean, risk factors, they are all the risk factors for placenta abruption. And they are seen in 57% of the women with retroplacental fibroids, in contrast to 2.5% of women with fibroids located in alternative sites. Again, the possible mechanism is the diminished blood flow to the fibroid and the adjacent tissues, and partial ischemia and decidual necrosis in the placental issues overlying the myoma. Placenta previa, again, not too many studies have shown, but there are two large studies which have shown an increase 1.5 versus 0.5%. Fetal growth restriction and anomalies, large fibroids can be associated with the fetal growth restriction, and they might compress and distort the intrauterine cavity and give rise to fetal deformities such as dolichocephaly, torticollis, and limb reduction defects. Malpresentations can again occur because of large submucosal fibroids which distort the cavity, and some of the studies have shown an increased incidence of breach at term. Again, causes are multiple fibroids, fibroids located behind the placenta, and large fibroids. Now, the dysfunctional labor has also been noticed with patients who have fibroid, and because of the decrease in the force of uterine contraction or disrupt the coordinated spread of the contractile wave, which causes dysfunctional labor. Several studies have shown an increased incidence of dysfunctional labor because of complicated fibroids. Higher rates of tachysystole have also been reported. Again, to see the incidence of cesarean delivery is more common when you have a fibroid with pregnancy, especially because of the location of the fibroid that is important in the lower uterine segment. And systemic review of women with fibroids have shown 3.7-fold increased risk of cesarean deliveries. And risk is more due to malpresentations, dysfunctional labor, and obstruction, and placental abruption. So most of these studies were biased in their selection of cases. Causal association is unproven. Now, these are again cervical fibroids, which we have seen in our cases. Incidence of postpartum hemorrhage with fibroids, reports are again conflicting. It could predispose to PPH because decreasing both the force and coordination of the uterine contractions, mainly because of an atonic postpartum hemorrhage. Several studies have shown an increased risk of postpartum hemorrhage when the fibroids are large, when they are located behind the placenta, and delivery is by C-sections. Now, other studies have also shown that there is no association between fibroid and PPH. Retained placenta, again more common in women with fibroids located in the lower uterine segment, but however, the pooled cumulative data shows that retained placenta is common in all women with fibroids compared with control subjects. How do we manage pain or red degeneration due to red degeneration in pregnancy? Mostly it is a conservative treatment with bed rest, hydration, and analgesics, and prostaglandin synthetase inhibitors like NSAIDs could be used. But you cannot use it more than 48 hours, so they are associated with fetal or neonatal adverse events like PDA, pulmonary arterial hypertension, necrotizing enterocolitis, and intracranial hemorrhage or oligohydramnios. Rarely severe pain need additional pain medications like and epidural analgesia or surgical management. Now, these are some of the studies done which is reported in AJOG 2008, where they found that with the fibroid, all these problems are much more common compared to those who do not have fibroids. Antepartum myomectomy. Now, antepartum myomectomy, I think why are there some of the slides not coming? Yeah. Controversy persists among the reports of myomectomy being performed during pregnancy. This is something that we need to think over. Management of uterine leioma during pregnancy is largely expectant. We do not go for a surgical method immediately when we see a fibroid. Sometimes you do need surgical removal, but generally delayed until after delivery. Mortality and morbidity is slightly higher in myomectomy in the gravid uterus as compared to the non-gravid uterus. Now, when do we do antenatal myomectomy, antepartum myomectomy? When you have severe abdominal pain which, due to torsion of a subserous pedunculated fibroid, or a red degeneration which does not respond to your medical treatment, or a rapid increase in the myoma size causing abdominal discomfort, which it has been reported that if symptoms persist for more than 74 hours of therapy, probably a surgical intervention should be considered. So recommendation from authors of case reports, Burton et al., Mollica et al., they say that myomectomy in pregnancy should be confined to symptomatic myomas which are pedunculated with a stalk of 5 centimeters. Criteria for antepartum myomectomy is largely rapid growing myoma or a large or medium myomas located in the lower uterine segment or a deformed placenta. Again, the study by Pawan, Jalta et al. In 2016, they have shown that there are no pregnancy losses with antepartum myomectomy in indicated myomectomies. Now, this is another study reported where there are 13 women have studied, they have done an antepartum myomectomy, they found 92% successful rate, and the blood loss was noted to be very minimal. Why are the slides not coming up? Why is it not coming? So the advantages of antepartum myomectomy with the reversal of fetal complications like oligohydramnios, fetal postural deformities, and intrauterine growth restriction. Disadvantage, of course, we all know that the incidence of miscarriage and abortions are much more common. Mode of delivery after antepartum myomectomy is mostly elective cesarean section, but however, vaginal delivery could be considered if there is a pedunculated fibroid which has been removed and myoma not, and the uterus myoma not being involved. Now, in our center, we have had 4 cases where we have done antepartum myomectomy in the last 10 years. Out of the 4 cases, we had 1 case where the myoma was rapidly growing, and in 3 of the patients, we did it for severe pain, which was not responding to conservative line of treatment. 2 of the patients were 14 weeks and 2 of them were for 12 weeks. The first patient had a fundal subserous fibroid of 20 to 15 centimeters, which was weighing 2.5 kilos. She wanted an abortion, but then I said no abortion. So we tried myomectomy in this patient and we succeeded and delivered her by cesarean section at term, at 38 weeks. The second was an anterior degenerated fibroid, again severe pain. All these 4 patients came to us wanting for an abortion, but then we managed to give them an antepartum myomectomy and succeeded them to get a live baby at term. So the second patient was an anterior wall degenerative subserous fibroid of 15 to 10 centimeters. The third pregnancy was multiple fibroids, large, just 2 minutes more. Largest fibroid was 8 to 10 centimeters, and the 4th patient was a left-sided broad ligament fibroid. So we used vasopressin. Of course, you all will be surprised to see me using vasopressin, but the amount was very small. We injected into the myoma, and we had 3 of them going for cesarean, 1 for normal delivery. So the decision to perform a myomectomy depends upon the fibroid size, location, and rapid growth. So those who are the fibroids prolapsing into the vagina with a pedunculated fibroid, you could easily remove even in the antepartum period. So indications for cesarean myomectomy, there are 7 opinions. Leave it with the uterine artery ligation, removal of the pedunculated fibroids only, removal of pedunculated fibroids, anterior subserous fibroid or lower uterine segment, remove all anterior uterine fibroids, remove all fibroids or selective removal of fibroids. So most often we go for a selective removal of fibroids, and it should be done by an experienced person, well-equipped tertiary center, better anesthesia and availability of blood with a full consent from the patient. And the techniques for decreasing the blood loss should be in the form of tourniquet or electrocautery, uterine artery ligation, UAE, high oxytocin, and we use routinely vasopressin in our practice. So there are a lot of studies which have shown and are in favor of myomectomy during cesarean delivery. And the incidence of hemoglobin drop, the time taken are not much compared to the patients who have had a routine cesarean section. So it is a safe procedure. They have done, that is a retrospective study of 361 patients where they have studied with regard to demographics, drop in hemoglobin, complications. They did not really find any difference. And cesarean myomectomy in modern obstetrics, they have more light and fewer shortage. The authors have conducted a literature and they found that they strongly suggest a safe cesarean myomectomy, and the data on the long-term outcomes of cesarean myomectomy in women are lacking. So our experience in Ganga women, we have done 86 patients out of the 4,032, and we have successfully done without much of complications. We have not had any patient who went for blood transfusions. To conclude, fibroids are common in women with reproductive age group. Majority do not change their size during pregnancy. 1/3 of them grow in the first trimester. Size and location appears to be the risk factors for pregnancy complications. If there is more than 5 centimeters, retroplacental location or distortion of the uterine cavity are associated with the increased risk of obstetric complications. So carefully planned antepartum myomectomy in selected cases is an appropriate low morbidity option. Cesarean delivery is performed only for standard obstetrical indications. Myomectomy during cesarean section does not increase the complications or transfusion rates and appears to be a safe procedure. Every effort should be made to avoid cutting through the fibroids at cesarean delivery. The risk-benefit ratio of cesarean myomectomy should be re-evaluated in the new century, given the increasing patient's age, incidence of myoma in pregnancy, and the wide use of ART procedures. Thank you.